Okay, well, it's gone 7:30. So again, thanks everyone for joining us tonight for another grand random session. Tonight, we're fortunate enough to have a haematologist, Anya, joining us, and she's going to talk us through an approach to abnormal cell count results. Anya works in South Australia, and she's a private haematologist, works for Genesis Care, so more than happy to see any haematological patients that you may want to refer that way. So I'll just pass you over to Anya.
Sure. Thanks for having me. And please ask questions as we go through. I'm happy to keep it fairly informal. I've made some slides, but hopefully they're just springboards for discussion, and we can go on some digressions or skip some depending on how the talk's going. But yes, as mentioned, you may have heard me talking to Jared. This is full blood count, full blood examination is something you're going to be ordering almost every week. And often there are abnormalities, and you've got to think about what to do with them. I'm sure you see this in your daily practice. So this is a brief overview. I've made fished out a few really quick cases that are of patients I've seen this year, and I thought they could be a springboard for discussion about some red flags in these situations, or next steps in investigations and who you need to worry about. There's a little bit on iron studies, and we can talk a bit about myeloma and MGUS if interested, as well as chronic lymphocytic leukemia, and this thing you may get reports back on, monoclonal B lymphocytosis, a kind of precursor condition to CLL. So we'll start with this lady who I met this year, her Mrs. JN, who's 77 with a history of hypertension, high cholesterol, and comes presented to her GP with fatigue. And these are the initial results in August. And you can see she's a bit polycythemic with a hemoglobin of 165. Other cell counts are normal. I put her iron studies here too, and you'll see the ferritin is quite low. So she's polycythemic, but she's iron deficient. So how would you put this together? I suppose my first thought always is this a new finding, or how far back has it gone? And that's true for any blood result, because usually if it's something that's mildly abnormal and been present for 20 years and hasn't changed over that time, it's often not particularly clinically significant. In this case, with all the polycythemias, the first step really is to definitely repeat it. The first thing to rule out is it an assay issue, or what we call pseudo polycythemia. It may be that it was a difficult venipuncture, potentially dehydration on the day of the blood test, diuretic use. So you can see this pseudo kind of concentration and not a truly increased red cell mass. The clue for me that something's abnormal here is that she's actually iron deficient. So she's got no iron on board. Her ferritin's less than 30, but she's still making lots of red cells. And the next step here, then you really got to think of it's a bone marrow condition. You're autonomously making red cells. You're running out of all the iron you've got, but you're still making red cells. So this is the next step in this case is JAK2 mutation. And this lady turned out to have polycythemia vera. So this autonomous production of red cells with quite high thrombotic risk. So needs to be treated. So this is a bit how I think about it. So the first step, is it pseudo polycythemia? So just repeat the test. Is it truly high? How long has it been present for? And then the working out, is it primary or secondary? And by that primary, I mean it's a bone marrow problem, which is unusual, but there's an autonomous production of red cells. There's no off switch. Whereas secondary it's an appropriate physiological response to low oxygen, usually low EPO, with normal EPO. So in primary polycythemia vera, the primary, you have low erythropoietin. So remember, erythropoietin is made in the kidney when the kidney senses low oxygen. So for example, you're very anemic, the kidney sensing that and telling the bone marrow to stop making red cells. In polycythemia vera, that doesn't happen. So you've got a very low EPO level, your iron stores might be reduced. 96% of people will have this JAK2 mutation, and that's just a peripheral blood test. So if they don't have that, you're almost certain they're not going to have polycythemia vera or a bone marrow condition. So the secondary polycythemia is the bone marrow is making more red cells, but usually that's appropriate. Usually there's a chronic low oxygen state, and the kidney sensing that and telling the bone marrow, please make more red cells because we're not getting enough oxygen here. So the most common things are usually COPD, and often sleep apnea gets forgotten about, but it can happen a lot in sleep apnea. The other thing I sometimes see is exogenous testosterone use. I have seen a cyclist who was using synthetic EPO as well that was leading to it. So it's almost always lung disease, though. Very rarely it can be erythropoietin secreting tumours, but this is really, really very rare. So I suppose the first step in polycythemia is look at the iron studies, check it's real, repeat it, consider a JAK2 mutation and look for these risk factors. Could they have sleep apnea? Do they have a history of lung disease? From our point of view, when we're seeing these patients with PV, we're aiming to get the hematocrit less than 0.45. Everyone gets aspirin. High-risk patients such as this woman, just by virtue of her age and hypertension, would also have cytoreduction. So this is usually in the form of hydroxyurea to bring down the packed cell volume. And this always working in partnership with GPs to address other risk factors for cardiovascular disease, for MI, stroke in these patients. So this was just a bit of a reminder about EPO coming from the kidneys as a sense to anemia, low oxygen, and telling the bone marrow to make more red cells, which is why, of course, in kidney disease, there's anemia, and synthetic EPO is often used in kidney failure, excuse me. So just a reminder that sometimes there's a bit of confusion about iron and polycythemia. So, of course, iron deficiency can lead to anemia, but the reverse is not true. So high iron levels don't lead to polycythemia. So whilst you need iron to make red cells, iron doesn't drive erythropoiesis. So if you've got a lot of iron around, you're not making more red cells. So hereditary hemochromatosis, which leads to iron overload, you get iron deposited in your organs, but you're not making more red cells, so it shouldn't cause polycythemia. So if there's polycythemia and hemochromatosis, you need to think of another cause for the polycythemia. So this is a quick segue into iron studies then.
Just before we move to that, with the polycythemia, is that a immunosuppressing condition by itself?
Not particularly, no. So not really. The treatment we give for it, the hydroxyurea, it can lead to a neutropenia. Not often, but it's something to keep an eye on. But they're not usually at risk of infection at all.
Right.
There is a small risk.
Live vaccines and those sort of things?
Yes, of course. Yes, absolutely. There's a long-term risk. If you've got that disease for many years, there's a small risk of it developing into an acute leukemia or something called myelofibrosis with a really scarred bone marrow. And both of those have a pretty poor prognosis. It's very difficult to predict who will progress to that. And there's nothing we know that can prevent that progression at this point.
Yep.
And of course, at that end stage, they will be immunosuppressed, but most of them not. Yeah, good question. So yeah, I just put up some iron studies again, because this is another really common test. And just a reminder that, of course, ferritin less than 30, you're iron deficient no matter what. But a reminder that ferritin can be an acute phase reactant, so it can mask iron deficiency. So often ordering a CRP at the same time, it can be useful. So if your CRP's up and your ferritin's in the normal range, it can be masking potential iron deficiency. But ferritin less than 30, of course, is iron deficiency, and you need then to think about, of course, what is the cause? Is it menstrual losses? Is there occult gastrointestinal blood loss? Is it malabsorption from celiac disease or other gut thing? There's a few things to work through. In chronic disease, ferritin can be normal or raised. However, the clue often is you have a low transferrin or low with the transferrin saturation. I haven't put up high ferritin here. If the ferritin is high, but the transferrin saturation is normal, that's really not iron overload. So hereditary hemochromatosis will come with the two, high ferritin and high transferrin saturation. If the transferrin saturation is normal, it's not hemochromatosis, and the high ferritin is almost always due to metabolic syndrome, obesity, liver disease, fatty liver. For example, I saw a patient today with this, a ferritin 900. Looking back in his bloods, it looked like he might have impaired fasting glucose. BMI was 35. Next step for him really is abdominal ultrasound and having a look at those metabolic syndrome, the risk factors. So any questions? I mean, this is not fully explaining all the iron studies. Any questions about iron studies before I move on? No worries. I feel like everyone's pretty good at iron studies in general. So I'll move quickly on to anemia. Of course, anemia is super common. And the best way to think about it, as we all learned it way back when in medical school, is to look at the MCV. So is the anemia microcytic, normocytic, or macrocytic? And this can give you a lot of information about what it is. So here's a reminder, the microcytic anemia, so the MCV less than 80, thalassemia. The thing to note though, if you look back in time, they must have been microcytic their whole life. So they can't have developed microcytosis in their 60s. Of course, you're born with thalassemia, so they should have been microcytic forever. So looking for, if you have someone with anemia and not sure what's going on, if they're not microcytic, it's not thalassemia. If they're microcytic but haven't been for their whole life, it's not thalassemia. So you can kind of put that one out of your mind. The only exception to that, I suppose, is a sickle cell disease that won't have a microcytosis, but you'll see that on the blood film, and it will be mentioned, and it should be in the history, picked up much sooner. Anemia of chronic disease can give you a microcytic anemia. It's a bit unusual. Usually it's normocytic, but it's possible. The number one, of course, in Australia is iron deficiency, and the next step is iron studies. The other ones are really unusual. I've never seen lead poisoning, but it's on the list. So, and the biggest group is the normocytic anemias, of course, anemia of chronic disease and renal failure. So this will often be around 100, 105. Maybe there's autoimmune disease, there's lupus, there's rheumatoid arthritis, chronic kidney disease are the main ones. Bone marrow disorders can be there. I mean, the things to think about with bone marrow disorders is usually there should be something abnormal on the blood film, or you have associated neutropenia and thrombocytopenia. So it's usually part of a pancytopenia. Usually there are blood film changes, and it's not something that has been evolving over many years. Hemolysis I wrote there, but hemolysis is also often in the macrocytic place, because when you're hemolyzing, you're breaking down your red cells, your bone marrow is trying to respond to make more red cells, and they pump out reticulocytes. Reticulocytes are big cells, so they raise the MCV. Mixed deficiencies, so you're iron deficient, but you're also vitamin B12 deficient at the same time. And you can see this in gastric bypasses, for example. You can see it at-risk people in nursing homes, and you can have a normal MCV, but you still have those dual deficiencies. The macrocytic anemia, on the other hand, the most common one is actually alcohol. So even without anemia, a macrocytosis is often alcohol excess or indeed liver disease. The megaloblastic anemias are really the vitamin B12 folate deficiencies. Interestingly, that can present as a pancytopenia, not just anemia as alone. So you can, the B12 and folate deficiencies can drop all your counts. Pregnancy, third trimester in particular, raises your MCV. Certain drugs, methotrexate's the classic for rheumatoid. So this brings me to the next case. This is a lovely gentleman I met this year, Mr. AB. He's 70. He also has hypertension. He actually fell into a wheelie bin when he was putting out his rubbish. And I really saw kind of chest wall rib, and that prompted all the investigations. And this is what his blood film looks like. These things called rouleau, the stacks of red cells. You see he's only mildly anemic. The first thing to note is the MCV is normal. But if you look at the biochemistry, these things together tell me it's almost certainly myeloma. The couple of clues here, of course, is the mild and new renal impairment, the elevated calcium, but this total protein. And this is a really good marker that I'd encourage you to look at if you've got an anemia of uncertain cause. If that total protein is elevated, it could be that there's a paraprotein floating around. And that puts it all together. So the anemia, the renal failure, the high calcium in the presence of a paraprotein. So I was going to segue a little bit into MGUS and myeloma then with this anemic patient. And this is my awful clip art about what is a paraprotein. So it is a monoclonal immunoglobulin or light chain that you detect in the blood, or in the urine, it's the Bence-Jones protein. So if you can imagine here, all these colored cells, those are all plasma cells, which are like B cells, and they're all producing slightly different immunoglobulin molecules, slightly different antigen specificities. So they're all a bit different. And the immunoglobulin molecule has these two heavy chains, and then it has two light chains attached to it. So they're all producing slightly different ones. When one becomes cancerous or clonal, they all look the same. They're all producing the same immunoglobulin. And this is what the paraprotein is. So it's telling you there's a clone of abnormal cells present, usually B cells or plasma cells. And that's when you are ordering the serum protein electrophoresis, they're picking up this paraprotein. So this is plasma cell neoplasms then. So what's the difference between MGUS, monoclonal gammopathy of uncertain significance, through to myeloma? So MGUS, there is a paraprotein, but it's less than 30. And there's, by definition, no end organ damage. So this is an asymptomatic condition. There are no bone lesions. There is no high calcium. There's no renal failure. There's no anemia. So this is the Crab mnemonic. So when you've gone to myeloma, you necessarily have one of the Crab criteria. C for high calcium, R for renal failure, A for anemia, B for bones. And those are lytic lesions in bones. So MGUS is on this end of it. About 1% of people per year progress through to smoldering myeloma. So this is still a condition where we have no end organ damage. We don't need to treat, but we continue to monitor. And it just means the paraprotein is getting a little bit higher, and they progress at a quicker rate to myeloma. It's very hard to know when you pick up MGUS who's going to progress and when. So it's something that needs to be monitored indefinitely, even though the risk overall of it progressing is pretty low. And it's really common, MGUS. So about 5% of people over 70. As I said, by definition, the paraprotein level is less than 30. So usually it's between 1 and 10, quite low level. You have to have no end organ damage. So if someone's got anemia as well, and there's no other cause for anemia, then you've really got to think that this probably couldn't be, it's not MGUS. No treatments required, but ongoing lifelong monitoring. Initially, often 3 to 6 monthly, and then can even be annual. It depends on the patient here. I'm happy to review such people on an annual basis. Some people would prefer with GP management and just to re-refer if they start noticing any of those kind of red flags, those end organ complications that are coming up. And just on a side note here, when we talk about paraprotein, usually it's IgA or IgG type. If it's IgM, it's almost certainly not myeloma. So that's exceptionally rare. The IgM ones are usually lymphomas. So instead of looking at the bones and all of those other things I mentioned, it's the first step, usually a CT, chest, abdomen, pelvis, to look for lymphadenopathy, hepatosplenomegaly. So they're often actually lymphomas. So when to suspect myeloma, as I said, think about CRAB. If you've got any of those CRAB features, think about it, especially if there's mentioned rouleau on the blood film, increased ESR, or that clue on the biochemistry panel that increased total protein. Again, if someone has new or worsening renal function, in particular, if there's proteinuria, think about myeloma. Back pain in elderly patients with anemia and renal failure. I know back pain is common, but when you see it with those other two things, you need to at least do a paraprotein and exclude an underlying myeloma. And then lytic bone lesions, pathological fractures, bone pain. So if someone's fallen over and broken their wrist and you can see it's actually a lytic lesion, think myeloma. So the workup is the paraprotein, the serum electrophoresis, also the serum free light chains. So there are a subset of myeloma don't make that whole paraprotein, they just secrete the light chain part of that immunoglobulin molecule. ESR, hemoglobin, calcium, creatinine, 24-hour urine, at least start with the spot urine, see if there's any protein in it, Bence-Jones protein. What we do is something called CT skeletal survey. It's a low-dose CT looking at all the bones. And this is something that is not commonly known. Bone scans are actually very insensitive for myeloma. So whilst they pick up the prostate cancer, myeloma will be completely silent on a bone scan. And it's mostly because it's all the osteoclastic activity, just eating away the bones. So that's why CT or even MRI or PET is required to look for the bone lesions. So a negative bone scan certainly doesn't rule it out. So that was a bit about anemia and MGUS myeloma. Any further questions on that topic before I talk a bit about white cells?
With the ESR, does the ESR increase with age, or is that just a standard?
Yeah, it's quite non-specific, isn't it? And it doesn't increase with age just because of aging, but usually because there are more inflammatory, autoimmune, chronic diseases, then you will see increase, but it reflects the chronic disease rather than the age itself.
Right. Okay.
So yes, it's non-specific, but it's pretty useful. If it's over 100, and you've got some of those other findings, you're thinking certainly myeloma is up there. But yeah, of course, infection will do it, rheumatological diseases, any kind of inflammatory process. So it is non-specific.
Yeah. And with the alcohol and the macrocytosis, how much alcohol is needed for that macrocytosis?
Yeah, there's no hard and fast rule, but but usually I find it's someone that's drinking at least every day.
Yeah. Because it's quite common. We see people that drink all the time and they've always got this macrocytosis.
Yeah.
It's
yes, it's interesting. And I don't know the mechanism, how it does that, but it's really common. And, not many people are anemic with it, but they've got that kind of macrocytosis that just goes along. I think I'd probably in that setting just check their thyroid function, make sure you're not missing hypothyroidism.
Yeah.
And their B12 folate in the first instance. And if they're normal and they're not anemic, I would just monitor, their liver function and their hemoglobin every 6 months or so. I don't think I'd chase much further. All right, so lots of different white cell abnormalities. These are the three most common ones I get referred, which is why I thought I'd chat about them. So this is case 3. Excuse me. Again, another lovely woman I met this year in her 80s with the past medical history listed there. and she's just come for her annual checkup. And this is what her hematology looks like. This is the most recent sample in June, and you'll see the lymphocyte count is low, 0.6. But I think the thing that tells me already that I'm not going to be too worried about this is back in 2009, you can see it was very similar. So already, again, it's the chronicity of the problem. It's the absence of symptoms. It's the absence of anemia, thrombocytopenia. It's the absence of any problems on the blood film that already tell me this is probably not going to be clinically significant, especially as she's presenting for her annual checkup rather than with a pneumocystis pneumonia. So here are some of the causes of lymphopenia. And the first one is, in this setting, is aging physiological. So if you test every 90-year-old, most of them will have low lymphocytes. Infection, and this is more recent infection. We see it often with COVID, actually, I've seen. For the 4 to 6 weeks post-infection, you can get quite a low lymphocyte count, which will return to normal on its own. So that has caused the lymphopenia rather than the lymphopenia causing the infection. So it's the reverse. HIV, of course, but this is not really how it presents with an incidental lymphopenia. Systemic disease, so particularly lupus and other autoimmune diseases will have a low lymphocyte count. Again, usually presenting differently. I'm sure you're very well practiced in this compared to me. Joint pains, rashes, not presenting with an isolated low lymphocyte count, feeling well. Malignancy and lymphomas can do it. Again, the presenting symptoms are different. You have night sweats, there are fevers, you have unexplained lymphadenopathy. Surgery post-operatively for the first week or so can do it. Malnutrition, so I have seen another woman this year with an eating disorder who has a very low lymphocyte count, and that's a direct result of her very low calorie diet and malnourishment. Chemo radiotherapy, all the chemo we give causes them to plummet, but and of course, more relevant than chemo for general practice is steroids, long-term prednisolone use. That's how steroids work at high doses, is they kill off lymphocytes. So you can have a lymphopenia if you're on steroids. If you have recurrent COPD exacerbations and on, often lots of courses of steroids, you can have a low lymphocyte count. So I suppose the take-home point is it's really common, and if it's in an otherwise well patient, it's unlikely to be of any clinical significance and doesn't require any further workup or investigation. So this is case 4 now. This is the opposite. This is a lymphocytosis. So this is Mrs. GS. She's 55. She has a history of hypertension and anxiety, and she's presented with fatigue and sweats. Unclear if the sweats are true night sweats or menopausal. So this is her count. This is 2nd of June, and her lymphocyte counts are 13. You can see they were up in January, so we know they've persisted for 6 months, and normal in 2020. The blood film shows the smear, smudge cells, and otherwise normal looking lymphocytes. So already I'm thinking, just because of the level of lymphocytes, this is probably a lymphoproliferative disorder. So some kind of cancerous lymphoproliferative disorder, producing too many malignant lymphocytes. Why I say that is, firstly, I know it's persistent. It's not just the one-off test. And we've got these, the level it's high enough to be worried about that. If it's 4 or 5, it's not necessarily the case. And you've got the smudge cells on the film. The smudge cells, of course, aren't completely diagnostic of it, because they're just smashed up lymphocytes as you spread the film. But it tells me it probably is. So the next step to do, persistent lymphocytosis unexplained, is the LSMs, the flow cytometry test, the lymphocyte surface markers. So this is what it looks like. This is some of the things I report at ClinPath. They're dot plots. We're putting the blood through, and we're staining it with fluorescent antibodies. The antibodies are are binding to the antigens on the cells and fluorescing as they go through the laser. And so I can tell each cell gets interrogated individually, and you can say, oh, that cell's got that marker on it, so it must be this. And so this is actually chronic lymphocytic leukemia. So the key words here is a surface light chain restriction. So when I was talking about the paraprotein before with the light chains, the clone, you have a clone of cells, they're all producing the same immunoglobulin, so they're all going to have the same type of light chains, and that tells you it's malignant. Hopefully we write a nice report for you. So so I won't talk a bit about flow cytometry, but when should you order them? When should you order lymphocyte surface markers? Definitely if there's a persistent lymphocytosis, I think I would consider it. If there's unexplained neutropenia or pancytopenia, it's a useful test. Or of course, if there are abnormal cells in the blood film, we'll probably recommend it in the blood film report, but then it can be a helpful test. When it's not particularly helpful is when the blood, there's a normal FBE, so normal full blood count. It's rarely helpful in that setting. If the white cell count is elevated because of neutrophils or monocytes, the lymphocyte surface markers are really not going to tell you anything, except if there are blasts on the blood film, which we will see down the microscope. So it's pretty unhelpful in that setting. So these are some points I'd like to make as well. If you're worried someone has lymphoma, doing this test on the peripheral blood, especially if the peripheral blood counts are normal, doesn't exclude it. And it almost will always be normal, even if there's lymphoma. Most lymphomas aren't in the bloodstream. They're sitting in the lymph node, and the clonal cells aren't in the bloodstream. We can't pick them up with this technology. So if someone's got a big lymph node, night sweats, you do this test and it's normal, it doesn't tell us, it doesn't help particularly. You've got to obviously go to the lymph node. That brings me to the next point. The flow cytometry on the lymph node if that's normal, you could still have lymphoma, especially Hodgkin lymphoma, in which the flow cytometry is almost always normal. So this is always the issue then, is a really good biopsy and histological examination. So if you're worried someone's got lymphoma, you need a biopsy. Usually start up with a core biopsy, and then if that's unhelpful, straight to excisional biopsy. And this brings me to the point, if someone has normal blood counts and you perform the test, it's often not helpful, and it might pick up a very small clone, something that could develop into CLL in 20 years' time, or maybe never. And I've found it leads to a lot of anxiety. And this is certainly a tricky situation, because I have recommended sometimes on blood films, maybe consider this test. The lymphocyte count's kind of very mildly low, mildly elevated. And then suddenly someone has this diagnosis of, say, chronic lymphocytic leukemia, a chronic disease. And then we're meeting them and saying, oh, we actually don't need to do anything about it. And we might never need to do anything about it. And it can be quite psychologically distressing. Especially as all of the healthcare messaging is, you want to find breast cancer early, treat it. If it spreads, it's bad news. And it's different with some of the lymphomas and the chronic leukemias, like chronic lymphocytic leukemia. Certainly finding it early is not necessarily very helpful. And it may be you live another 30 years with no problems. So I suppose that brings me a bit to this point on something called monoclonal B lymphocytosis. So this is a precursor asymptomatic condition to chronic lymphocytic leukemia. The only difference is they're the same kind of cells. They've got the same things on them on flow cytometry, but the level is different. In monoclonal B lymphocytosis, they're between 0.5 and 5. Once the level hits 5, you have CLL. So that's the only difference. If you have this precursor condition, only 1% of people per year go on to CLL. And even if they make that progression, which was very difficult to predict when we meet them, we still might not need to do anything about it for some time. We do need to treat when it becomes symptomatic. This is usually heralded by anemia, thrombocytopenia, really bulky lymphadenopathy. So in general, 8 centimeters, not 1 or 2 centimeter shoddy lymph nodes. And if the lymphocyte count is rapidly doubling, so it's 20, 40, 80 within 3-6 months, that tells us the CLL is taking off. So this precursor condition is certainly something that may require monitoring, usually only annually with blood tests. And this can lead to a lot of anxiety, I found, especially if it was done on a normal full blood count. So the other thing, this is another one to notice, there's another form of monoclonal B lymphocytosis similar to this, just the numbers less. If the number's less than 0.5, we know from huge data sets that it just never goes to CLL, doesn't require monitoring. It is reported in flow cytometry. I'm not sure if we're doing anyone a good service by reporting it in that setting, but it doesn't go on to lead to problems. On the other hand, if you've got a clone of B cells that don't have the right surface markers for CLL, so the cells look a little bit different to CLL, it's really hard to give good advice on this. This is probably warrants a referral, as the course is very unclear. It could be a nasty lymphoma, or it could be absolutely nothing, and it's a bit hard to tell. So what else could it be? Smoking, actually, usually a lower lymphocyte count than we saw in this lady. In that case, the flow cytometry will just show a polyclonal rise in T and B cells. But smoking certainly can do it at low levels, a lymphocyte count of 4 chronically. Viral illness. So before, when I was saying viral illness can cause a lymphopenia like COVID, other ones, the classic one you will probably see is glandular fever. So they get this lymphocytosis, you see the LFTs go off, and under the microscope, they've got big, ugly, reactive-looking lymphocytes. And they will have that high lymphocyte count that'll return to normal. Usually I'd check it probably in 3 months' time just to make sure it has gone back to normal and it's not hanging around. The case I presented was CLL. Another thing called mantle cell lymphoma can do it, and we will let you know on the lymphocyte surface markers which one it is. Common one, splenectomy. So, and these patients, the blood, you'll know about the splenectomy from the history. The blood film will show changes of splenectomy. The red cells are very characteristic and will be written on the report, and it goes along with a thrombocytosis. So the platelet count will be 450, 500, and there'll be a mild lymphocytosis. Autoimmune disorders, whilst I said they can cause lymphopenia, they can also cause lymphocytosis. So post-trauma, again, very short-lived. Any cause of kind of inflammation can jump up the lymphocyte count. Okay, so this is the next case. We're still talking white cells. This is Mrs. LL. She's 66. So her history is significant for breast cancer many years ago with a lumpectomy alone. So importantly, no chemo or radiotherapy. Current medications are there, a statin and thyroxine. She comes in with tiredness and dry eyes. And these are her blood counts. So the most recent one, she has a mild neutropenia of 1.1. And you can see it's been there for over 5 years. Certainly it's a little bit lower this time, but it's chronic. So already this blood picture, there are no red flags to me. In particular, there's no anemia, there's no thrombocytopenia associated with it. Also, it's been 5 years and there's been no dramatic change with the neutrophil count. The other thing is also the level. It's not, usually the cutoff is about 1 where you start getting a little bit worried. Over 1, chronic, no anemia, no thrombocytopenia, and no changes on the blood film. It all looks normal. So this actually turns out to be Sjogren's disease. The dry eyes was the clue. Autoimmune diseases certainly can cause this kind of mild chronic neutropenia, and it can fluctuate a bit with flares in the autoimmune disease. So what are the other causes? Infection, or we talked about what it can do to lymphocytes, but it can also crash your neutrophils. So again, we think about neutropenia being a cause and increased risk of infections, which is absolutely true, especially less than 0.5, but also infection can cause the neutrophils to drop, but that should only be temporary. I saw a blood film recently of a little boy, 7. He had influenza B and his neutrophils crashed to 0.4. Later, 4 weeks later, you see that 2 weeks later, neutrophils are completely normal again. So it can be reactive to infection. This absolutely needs to be followed up to see its return to normal, especially when it's at those levels less than 0.5, especially. So medications, of course, chemotherapy. There are idiosyncratic reactions to anticonvulsants, antipsychotics. So clozapine, for example, usually newly started, so not someone that's been on their antipsychotic for 10 years. It'll be at the start when they've been first prescribed the drug that you can see the neutropenia. Autoimmune disorders like Sjogren's, as we talked about. So B12 and folate deficiency, it's always worth checking, not just anemia in this setting. Bone marrow infiltration. And I'll talk a bit about the red flags again next, which might suggest it could be a bone marrow disorder when you're having neutropenia, or if it could be bone marrow failure. Hypersplenism, so big spleen. Whilst I said your lymphocytes and you can get lymphocytes and platelets going up, you can also have neutrophils go down a little bit, but usually not very much. Kind of this outdated term, but this entity called benign ethnic neutropenia. So there are some people of African heritage that will have a naturally lower neutrophil count just because the reference range is based on a Caucasian population, and that will have no clinical significance. So it doesn't mean increased risk of infection, but it may be chronically sitting at 0.9 with no sequelae. So here are some of the red, this is before the red flag, this is kind of an orange flag. If it's persistent and unexplained, 0.5 to 1, these are all worth referrals. Really needs someone to look into it. These are definitely the red flags. So the neutrophil count, AN's absolute neutrophil count less than 0.5. So the risk of infection really skyrockets here. And if, I'm not sure if any of you work in ED, you may do febrile neutropenia, medical emergency. There are well-published guidelines for approach to treatment. You know, you want blood cultures off and antibiotics given within the hour. Another red flag, if it's part of a pancytopenia picture, so the one I showed you wasn't too concerning as it was isolated. If there's associated anemia, thrombocytopenia, that's more concerning, especially if there are blood film abnormalities. So if someone's mentioned dysplastic changes, blasts, leukoerythroblastic blood picture, and this will all be written down, that's also a red flag. There could be bone marrow pathology. Another one that you'll see is potentially increased LDH. So another relatively non-specific marker, but just if you combine a few of these things together, you start getting more and more worried about bone marrow pathology. Fever, constitutional symptoms, bone pain, night sweats, weight loss, lymphadenopathy and splenomegaly, and recurrent or unusual infections. So pneumocystis is one I mentioned before, one of these weird opportunistic infections. Excuse me. Definitely is something to worry about. So I rambled on for a while. I'm very happy to take questions. These are some of the points I brought up tonight. So polycythemia, high hemoglobin with a decreased ferritin may indicate polycythemia vera. Lymphopenia in a well patient is often clinically insignificant and probably doesn't need follow-up. Red flags with neutropenia, I've just been through them, but especially a neutrophil count of less than 0.5 is really cause for concern. A persistent lymphocytosis, especially in an older patient, is often CLL or MBL, that monoclonal B lymphocytosis, is an asymptomatic precursor condition to CLL, may never become CLL. You can have it for your whole life. Normal blood flow cytometry, the LSMs, doesn't exclude lymphoma. Get a biopsy if you're worried about lymphoma. Myeloma, think about it when there's anemia, increased ESR, and the total protein on the biochemistry. So next step is look for paraprotein. Bone scans are insensitive for myeloma bony lesions. A normal bone scan won't rule it out. And MGUS, monoclonal gammopathy of uncertain significance, is a common precursor condition to myeloma that does require indefinite monitoring. Thank you. And I haven't even mentioned platelets and other white cell abnormalities. There are so many different ones. So I'm happy to take questions about any other cases you might have, or questions on other blood count problems. Thank you for your attention.
That was great, Anya. Really enjoyed the presentation. You sort of discussed everything we see in primary care all the time. So we'll throw it open to the group. Are there any questions there?
I've got one. It says, happy that GPs start first-line workup for suspected MM. Yeah, I think you can do it in parallel. So if you're worried about MM, I think you can either pick up the phone to your friendly haematologist or send a referral, but start ordering some tests at the beginning. So, and the first step, I think, would a spot urine sample for urine for protein and Bent-Stone protein. So I think I'd probably do in parallel, but
Any other questions from the group?
I have another on the chat. If the MCV is raised due to chronic alcohol, how rapidly would it return to normal if someone ceases drinking? I'm not sure on that one, actually. I don't usually see these patients. That would be, if anyone else has an idea, I don't know. I think it's not doing any damage having the high MCV. I try and reassure patients that, but the underlying cause of it is the thing that could cause the damage. So I'm not sure about that one. That's an interesting question.
Yeah, all I've seen historically is it lasts a long time.
It does, yeah. The next one, I have a couple of patients with platelets repeatedly over 400 but under 500. Can I keep monitoring? That's difficult to answer without more clinical context. I mean, it can just be inflammation, infection causing the high platelets, but if it's consistently there and you don't have splenectomy and there isn't high neutrophils along with it to suggest there might be an inflammatory cause, it can be early essential thrombocytosis. So it is possible, even at a relatively low level, to be a bone marrow problem where you're making too many platelets. So I think that's it depends on the clinical context, but it might be worth referral just to consider that, especially if it's isolated. So if there's no anemia, no neutropenia, high platelet count without inflammation, without splenectomy. The only other thing to say is it can be iron deficiency. So make sure there is an iron deficiency that can cause your platelet count to go up to that mild level, 450, 500. So if it's not that, it might be worth a referral to think about essential thrombocytosis, because if that is missed, people can get clots. Then thank you. So next question, would you mind talking a bit about lymphocytosis and smoking again? I missed what you said about flow cytometry. Yes, the smoking can cause lymphocytosis. Usually it's low level, so 4 or 5. When you do flow cytometry, the report will say there's no clone, so there's no monoclonal population. Usually you see the T cells and B cells, just the number is a bit high. And when I said it very quickly, polyclonal, which means the cells aren't cancerous, they're all slightly different. So it's just a reaction to inflammation. So you'll see a slightly high T count, you'll see a slightly high B count, but the report will say there's no clone. And when to refer versus monitoring with vague symptoms and lymphocytosis, that's really hard because, everyone seems to be tired, and there's so many reasons for fatigue, and it's hard to tease out. I think if there's lymphocytosis and you're not sure what the symptoms are about, it's probably worth doing the flow cytometry at least once, because then if it comes back and it's normal, if there's no clone, no malignancy found, then you can kind of not worry too much about it. So I'd probably do it as a one-off test. And then you can say, let's put that to bed. We don't have chronic lymphocytic leukemia or something, and not worry about it on each blood test when it pops up. How can we refer a patient to you? I may have another slide. Let me see. This is I don't look like this at the moment. This is Photoshop magic. I can't remember the details off the top of my head, but it's on the website with Adelaide Oncology and Haematology. So I consult. I know there are a lot of people possibly from the Adelaide Hills. I'm up in Adelaide Hills once a week if you have any patients that don't want to come down to the city. But the details are on the website. I think there's a generic email and a health link that I forget off the top of my head, I'm afraid. But even if you have, I'm not here just to take referrals. I'm also here. I'm happy to take phone calls if you want to chat things through about patients and you're not sure what to do next with funny blood results. I'm happy to take an email or a phone call, not a problem.
Thanks so much. That's much appreciated.
You're welcome.
Yeah, that was a great presentation. As Helen just said, like I said, it touched on everything we see in primary care. You made really complicated topics seem really straightforward.
Oh, that's good. It's hard to know how where to go, really. I could have rambled on for ages. Love blood tests, obviously.
Yeah. No, so look, we really appreciate your time tonight. The presentation will be available to review by everyone. That'll happen the next couple of days. The email will come out saying that. So yeah, thank you again, Anya. That was great. We really appreciate it.
Yeah, you're really welcome. Happy to help.
Excellent. Thanks so much.
Got out of putting my kids to bed tonight, so it was all good. Yeah.
Okay. Thanks so much. See you.
You're very welcome. Thank you.
Bye.